Find your seats. Hi, we're about to get started. If everyone can please find their seats. Please leave the back row available for families with wheelchairs. If everyone can please find their seats as soon as possible, we'd like to get started. If everyone can please find their seats as soon as possible, we'd like to get started. Okay, good morning. My name is Miriam Blaze. I'm with the Board of Directors for IFCR. Thank you. This morning's session is going to be a jam-packed one, so if you need to leave at any point, please quietly exit the back. Again, please leave the back row available for families with wheelchairs. Thank you. If everyone can please find their seats as soon as possible, we'd like to get started. Okay, great. So I'd like to start by introducing our platinum sponsor, Marinus Pharmaceutical, and their Chief Medical Officer, Lorianne Masuoka. Thank you.
Nice ad-lib, thanks. Hi, I'm Lorianne Masuoka. I'm the Chief Medical Officer at Marinus Pharmaceuticals. I'm very, very pleased to be here. I've been working in the area of CDKL5 since the last patient forum, and so this type of meetings had a great impact on us as a company. We made the decision that we were going to really look seriously about doing research in CDKL5 deficiency disorder at that meeting back in Rome last year. And long story short, we'll be talking later today about our first ever phase 3 program in CDKL5 deficiency disorder, which I believe is the first phase 3 ever to be accepted by both FDA and the European health authorities. So this marks, I think, a big turning point for the CDD community. I'm very pleased and proud to be able to introduce Tim Benke. Tim has been an advisor to Marinus since day one, not only in terms of trial design, but the kinds of outcome measures that we should be looking at and the kind of scientific endeavor that we would be taking on. He's taught us a lot about what CDKL5 deficiency disorder is. Tim is with the Children's Hospital of Colorado. He's a world leader in CDD, and I know that most of you know who he is. He's also one of the founding members of the Centers of Excellence that was set up between key centers and the IFCR, and his was, I believe, the first center. And I think that if I had to characterize one of Tim's greatest accomplishments and things that he brings to the CDD community is rallying everybody around the entire community, from industry to caregivers to academia, to work together to finding a cure for this disease. He is going to be speaking on the development of a clinical severity scale for CDKL5 deficiency disorder. I've watched all the hard work that he has been doing in getting everybody to collaborate around this consensus tool. And this tool is a very important step forward in terms of trying to really collect important data in many different settings, not the least of which is in my world. So we are very happy to see Tim taking the lead in this sort of thing. So we look forward to hearing his talk on the development of a clinical severity scale for CDKL5 deficiency disorder. Thank you.
Thanks, Lorianne, and thanks very much for all of you for being here. This is a trip just to have such a big group, and all the work that Amanda and Karen and Miriam have done to make this happen is really, it's really special to see. So I'll start with my first slide, but I want to ad-lib just for 9 seconds about a word that I think is really cool. Ubuntu. Can everybody say this word to me? It's fun to say this word, Ubuntu. So Ubuntu is a Swahili word. Now, if you're a software engineer, and I come from all sorts of sides of this, you know, oh, Ubuntu, that's Unix. That's this open source code. And the idea of Ubuntu is that everybody makes the code better. But the Swahili meaning of Ubuntu is you complete me. And so it's also this sort of notion that we're all in this together. And so I need you as families, as the clinicians, as pharma, to be in this together with all of us, Ubuntu, say this word again, so that we can come up with how we can approach CDKL5 better. So it's about perspective, and so what do you see here? Do you see a scary cornice, an awesome cornice, used powder, unused powder, warm cocoa at the bottom, nothing, I'm cold and my knees hurt. So these are the things that you can see when you see this. You could see all of them as well. So perspective, where are you? Optimist, pessimist, realist, physicist, or it's not water, or really it's me, the skepticist. You can't see me, but I'm in that water and I'm swimming and I'm trying to figure out how to make this scale work. That was Jenny's Downs' vision of what this was. So I want to show you this great video, see if I can get it to play. This is our friend Ava.
Good job. Good job, Ava. And are you talking at all? No,
So,
all right, Lily Ray.
Amanda sent me the video when this happened, and so I thought, how do you put a number or a score on that? We can't, but we have to, because it's all about what you can do. It's not about what you can't, but we have to come up with a way of quantifying this. So my talk is CDKL5 disorder towards a clinical severity scale. And basically, this is a hugely joint effort about a number of people. So I don't have any financial disclosures to make here. So what I'm going to talk about? So I'm going to talk about why do we need a scale. I'm going to talk about the IFCR Centers of Excellence, how we got here. I'm going to talk about CDKL5 disorder and the, quote, typical patients. And this is where I can hear all your eyes roll about what typical really is. Then we're going to talk about scales as a general concept, some features and issues. We're going to talk about RET as the clinical severity scale, about what was the initial severity scale, and I think that's my phone ringing over there. Then we're going to talk about where different scales have been used, both for the motor FOXG1 and tuberous sclerosis, and then I'm going to tell you about a suggested scale that we've evolved into. So why do we need a scale? Clinical trials. You need it in clinical trials because you're going to be able to say, is the drug doing something that we really think is helpful? We need a common data collection instrument because why should an Italian patient or a German patient or an Irish patient, Canadian, Australian, American be any different than anywhere else? You should be able to have something that works for everybody. We need it because in natural history, when a patient comes to see me, families are saying, what can I expect? Can you predict the future for me? And in the clinic, we've got caregivers, practitioners, and therapists, and we all want to know, am I doing anything to help you? And so that's why we need a severity scale. So why do you need to help? Because you, the families, the caregivers, are deciding what's important. It's your child. The FDA and other governing bodies need to know that the outcomes measured in a clinical trial are important to you. And this is the thing that we're sensitive about. Why should you fill out my 29th survey if it will not impact you? You guys are doing surveys till the cows come home. So this is where you write down my email address, and it'll be shown at the end of the presentation as well. I'll email you the scale that I'm going to show you today. I also have, this is it here. I've got a lot of copies too, and we'll get to why this file is important. And you can give me more feedback because I need more feedback from you. So the CDKL5 Research Consortium was through the International Foundation for CDKL5 Research Centers of Excellence. And so we started with 3 teams that are expanding. The University of Colorado, Children's Hospital Colorado. We've, scored now 42 patients, and we've got a big team. Scott does all the work. Margarita, Katie, Melissa, Tristan, who herds the cats. There's the Boston Children's site where they've scored 32 patients. The lead is Heather Olson there. Cleveland Clinic. The lead has been Sumit and Elia. Our goals were to come up with clinical care tailored to CDKL5 syndrome. We wanted to determine the standards of care and at the same time be a research platform to determine clinical profiles as a prelude to trials. So again, this is where you roll your eyes about what a typical CDKL5 patient is, because your child is not typical, but it's what our experience has been so far. So epilepsy is an early onset epilepsy. It's as early as 2 weeks, which may start with tonic seizures. There's often multiple seizure types. It's medically refractory. There's infantile spasms without hypsarrhythmia. There's a honeymoon period around 1 to 2 years of age, which may last for 12 months. And there's this thing called spasms and tonic spasm sequence that start after about 12 months of age. There's cortical visual impairment. There's abnormalities in how the eyes move. There's something called nystagmus. It can be roving, or the eyes can be disconjugate, and there's abnormal fixation. Development, there's global delays. They're often severe. Hand use develops slowly, and regressions are uncommon. There are other features as well about tone, sleep disturbances, autonomic and breathing disturbances, GI issues, and there's other EEG features as well that kind of got cut off on the slide there. But there's a clinical spectrum. The typical thing is where you roll your eyes. You know, there's a big difference. There's a wide spectrum in our experience. There's patients that walk, talk, have functional hand use, and these patients have different types of gene changes. You can be a mosaic male that has a group A change in your CDKL5 gene. And this is unclear how this influences severity. We're also seeing Parkinsonian features in some of our older ambulatory patients as well. So I think we need to start with the suggested diagnostic criteria for inclusion. You've got to have alteration of your CDKL5 gene, need to have some sort of confirmation that that alteration is pathogenic, needs to be an alteration which is nonsense in an exon less than or equal to 19, and if you've got a missense mutation, it needs to be present in the kinase domain and or not present in the parents or a normative database. I think you need to have an exclusion criteria, and we should, this is just a thought, CDKL5 duplication. So the clinical severity scales. It needs to be specific to the issues. There's some, it can't be too generic, but it can't be too specific. You know, the enemy, you can't have perfect be the enemy of the good. CDKL5 has unique features, and the scale needs to capture that. And it does not want, we don't want to overly weight specific issues. It needs to be useful. We want it to reflect interventions in a clinical trial. It needs to reflect severity. If possible, it it'd be nice if it was predictive. And I think it needs to be such that you can complete it in a standard clinical visit. That's tough. That's 30 minutes. It needs to be dynamic in order to be useful. It can't saturate. You need to have non-static variables versus static variables. So in other words, head growth versus head size. It needs to be eventually validated, but you've got to start somewhere. So the same patient needs to have the same score if evaluated by different people, and it needs to be obtained by a trained clinician. So let's talk with where the scale landscape is at the moment. When you read clinical papers, a lot of times they're using a RET scale. One of the common ones that's used is the RET Clinical Severity Scale. It's got 13 items, 0 to 4 or 5 points on each, and there's only one item on seizures and spells, which has to do with frequency. There are a lot of static items. There's minimal seizure issues, and it's a RET scale. So those are the main issues with that. The next scale is the Motor Behavioral Assessment Scale used for RET. Most of the items are frequency rated, whether the item is observed 0 to 25% of the time, 25 to 50, 50 to 75, 75 to 100. A bit subjective in there, how you do that. There's behavioral and social with 14 items. Seizures and spells, there's only one question. There's 7 items with regard to orofacial and respiratory issues, and there's 15 items with regards to the motor assessment and physical signs. The issues with this scale: minimal seizure items, a clinical assessment is required, and it's a RET scale. Another one of the RET scales is the Kerr scale. These items, there's a 0 to 2 range for all of the questions. There's 5 items on growth and development, 3 items on musculoskeletal, 5 items on movement, 3 items with cortical function. There's only 1 seizure question on frequency, and there's 4 autonomic items. So the issues with this scale is that there's several static items. Static, let me just define it again. That number is always going to be the same for you throughout your life. So that's not necessarily a helpful issue. There's minimal seizure items, and again, it was developed for RET. There's also Jenny Downs developed this, with Helen, developed a nice gross motor scale for RET. There's got 15 questions on gross motor. It's easy to use. There's 0 to 3 points on each. There's detailed instructions on how to use it. Issues, it does require a clinical assessment. It's limited to gross motor, but it's very detailed, and it's a RET scale. FOXG1 is another developmental encephalopathy. There's an inventory that's been developed. I won't go through all of these issues, but again, it was specific for FOXG1. It's nice because it's got modern phenotyping language, but it's not obtained by a clinician, and in its current version of how it's used, it does not assess movements, and it does not assess seizures. Tuberous sclerosis has developed a very nice scale with regards to assessing seizure severity, and has a lot of questions with regards to that. But some of the issues with this scale is it potentially saturates, it's limited to seizures, and it's really focused on tuberous sclerosis. So, how do you make a scale? I'm not a scale-making kind of person, so here's how this worked. We reviewed the literature. Oops. Make that go away. We considered our clinical experience. We talked to families. We talked to our colleagues, clinicians, scientists, pharmaceuticals, etc. We wrote something down. We then got feedback from families and colleagues. It's not a real Delphi process, but it's a process of asking people what they think to get feedback. We then looped around back to number 2, and we kept going until we got consensus on some of the questions, or not, because you can never get everybody to agree on everything. So this was initially presented at the CDKL5 Forum in Boston, and it's been reviewed was reviewed in a feedback session there, and that was in November. And we've gone through 4 cycles of this modified Delphi feedback. And so I need feedback from you today, and if I can give you a deadline, if that's okay. Deadlines are, I hate to say deadlines are soft because then you're not going to follow it, but really if you can give me feedback within the next 2 weeks, because we want to go on this. I would really like to publish and implement this as soon as possible. Majid said to me in November, I want the scale today. Here it is. So it's going to need to be refined through further use. And I know that it needs further input from a psychometrician to refine this more, but we want to start this. So who are our feedback partners? So there's been a lot of people that have helped us with feedback on this as we've gone through the loop. So it's been a lot of emails to go through and get everybody's feedback and cycle through this process. So how is this going to work? What does this scale look like? So it requires parental input prior to the visit. So we would need for a family or caregiver to fill out certain questions on the form beforehand. There's going to be a clinical review and parental input and an examination. And what the key thing is to focus on the last 30 days of how things have been going on with your child. There's 7 parts to the scale: epilepsy, motor, cognition, behavior, vision, and speech, some questions about autonomic function, overall impressions from caregivers, and then there's 2 things that are really not part of a scale, but really part of how, as a clinician, you would approach things. So what are the therapies that you're getting, and what would be the clinical decision-making that you would make based on that particular visit? So I can't go through every single question with you on the scale today and not have any time at the end of this for feedback. But I want to go through things in a way that lets you get the flavor for each of the questions. So I hope that you're able to read these from the back of the room. But part 1 starts with epilepsy, and so this is where the parent provides input, but then the clinician needs to go through with the questions to validate what the answers are, to make sure that you understood the question. So the first question has to do with the frequency of non-convulsive seizures, focusing on the last 30 days. So this is going to be absences or auras, which is pre-seizure activity that do not lead to an outright convulsion. So you're going to say, well, I've never had anything like that. You're going to circle a 0. Well, I've had none in more than 6 months, so you'll circle a 1. Or maybe monthly on average, no more than 1 per month, then you would circle a 2. Really on average, it's about weekly, so 2 to 4 per month. Then you'd circle a 3. Really, these are happening every day, 5 to 30-ish per month, then you circle a 4. Or we're having a lot of these every day, then you would circle a 5. So 0 to 5, you'd circle one of those, it's your gestalt in the last 30 days. Then I'm going to ask you, the next question is the frequency of convulsive seizures, again focusing on the last 30 days. And because seizures are so different in CDKL5, I've lumped a lot of things together in convulsive. It's tonic, clonic, or drops, and these are seizures that are disruptive and bothersome to the patient or family. How you define disruptive and bothersome is very different, but it's important whether it's disruptive or bothersome. If the convulsive seizure changes during the event to spasms or jerks, or vice versa, don't count it here. You're going to count it on the next question. So, for example, a hypermotor tonic spasm sequence is counted as 1 seizure in this question. So again, I never had anything like that, none in the last 6 months, monthly, weekly, daily, or more than daily. So then we go to asking you questions about epileptic spasms, focusing on the last 30 days. Epileptic spasms are myoclonic jerks that don't cluster. Then we're going to talk about how many different seizure types you've had in the last 30 days. Then I ask you about status epilepticus, or occurrence and duration in the last 30 days, and we give you a definition about what status epilepticus is. Then we talk about prolonged seizures. Prolonged seizures are longer than 5 minutes, but less than 30, so it's not quite status epilepticus. We talk about severity, using a maximum score, number of anticonvulsants used, not including VNS or the diet, number of anticonvulsants used in the last 30 days, and then whether or not you're on the diet or you have a VNS. And then we ask for a subjective parental impression of seizures in the last 30 days. And then this is a question that's based on my engineering background. I want to know your longest seizure-free period with a focus on the last 30 days. The next part then goes into a motor questions, and this has to do with the clinical exam. And the clinician is going to assess whether there's normal walking, walking independently greater than 25 feet, walking independently less than 25 feet, walking with assistance but less than 25 feet, or not walking at all. So this gives you a gradation as to how much help you need to walk and the different distances. And again, it's a 0 to 5 scale. Then we're going to go through the same question with standing, sitting, and then there's going to be an examination of hypotonia, weakness, and dystonia, which are abnormal fixed positions, which includes orofacial movements, chorea, and then whether or not there's contractures in the arms or contractures in the legs. Then we grade scoliosis, and we do a fine motor exam as well. There's also a question about stereotypies, which are the abnormal movements of their hands that are not better described as chorea or athetosis. And during the clinical exam, you're making an assessment of how frequent they are. The next part is behavior, cognition, vision, and speech. And again, this is clinical exam, but it's got this confirmation with parent or caregiver part as well. So the clinician is going to assess the alertness during the exam. And again, it's during a minimum 20 minutes of while you're there, you're asking questions, you're getting feedback, you're doing your exam, but you're also assessing during those 20 minutes what you're seeing. Are they alert the whole time or non-interactive at all during the entire exam? So 0 to 5. But there's a key question here is we then ask the caregiver, was this typical? Because we know we're getting just a 30-minute snapshot. Was this typical? Yes or no? The same goes for the questions with regards to irritability or crying. Again, we're going to assess this on a 0 to 5 scale and get an idea, did I catch you at a good moment or a bad moment? Self-injury, aggressive behavior. More questions on this. Hyperactivity, teeth grinding or bruxism, vision. Now, this is the tough one. We're trying to assess acuity, function, and attention. So we're going to ask about eye movements as well. Then we're going to try to assess speech, and then get a best assessment about nonverbal communication observed during the 20-minute visit. And so it's important that the families bring their device, if you have one, to the visit. So we might have to skip it if you left it at home or it was broken. This happens. I know how it is. You get it to the clinic, you turn it on, the battery's dead. I also think it's important to try to do a 2-object choice during the visit. Present things to our patients, 2 toys or 2 foods combo, give a verbal introduction. And so it's important that the family brings their favorite toy with them to the clinic so I can present them and say, which one do you want? Do you want my Pooh Bear or do you want my toy train? They may not like my Pooh Bear or toy train, but if you brought your toys that they like from home, I want them to choose which one they have, which one they want. I then look for receptive language, which allows for at least 30 seconds as a minimum of direct conversation that I'm having with the patient. I'm also scoring spells of irritability. And again, this is something that the family has to score as a separate item that I'm not necessarily going to see during the visit. Part 4 is autonomic. A lot of these are historical except for a few exam points. And again, we're focusing on the last 30 days. I'm going to ask about swallow function, reflux, constipation, breathing abnormalities. There's also part of the exam there. There's a peripheral autonomic exam where I've got to pull the socks off and leave for 5 minutes to see if they're getting cold or not. There's also questions on toileting, pain responsiveness, sleep. Again, this is historical. One of the issues that came up is everybody wakes up during the night, but the real issue is whether or not these arousals are disruptive to the parents. Do you have to get up or do they self-settle? Daytime sleepiness and infections are all asked on this question. Part 5, this is an important question about getting an overall sense from the caregivers. So in the last month, on your gestalt, are issues better, worse, or the same? If they're the same, you don't put anything here. But basically, if they're worse, I want to know on a scale of 0 to 5. 0, no change. 5, things are amazingly better or worse. Give us an idea where things are on that scale. 2 is a question about you. In the last month, how are things going at home? What is the adaptability of everybody at the home? Is it better, worse, or the same? And I want to know if it's better, 0 to 5. 5, it's doing the best it's ever been. 0, no change. Or if it's worse, 0 to 5. 5, this has just been the worst month we've ever had. So these are the 2 questions that we really need to know where things are with your overall impression with your child and with you. Now, these are the unscored items. I want to know what's going on with your therapies. I want to know how often are you getting physical therapy, speech therapy, augmentative communication, vision therapy, occupational therapy, feeding therapy if it's separate, and about all the other therapies that you're getting. If you're getting hippotherapy, if you're getting swim therapy, these are those things that we need to, nice to know, and I think it's also going to be important as part of any clinical trial, whether or not you're getting therapies at the same time, because that could theoretically influence what's going on with the drug. The next thing are visit notes. If you saw the patient in clinic, what were the sort of things that you were going to make recommendations about, things that you thought that the child would need, whether it's an EEG or an EKG or a swallow study or all those different things? What are your clinical decisions? So what are the issues now with where we are with this scale? So we haven't validated it yet in a cohort. I don't think it will saturate with epilepsy. It's got broad features. It requires clinical examination. I still think that there's a big question about can it be completed in a standard clinic visit. Sometimes I go fast, sometimes I go slow. Tristan, nurse coordinator, she knows that sometimes I'm slow. Most of the time that is. So I think it's a question of really whether or not it can be really completed in a standard clinical visit. And so I think that the big question that we're all having as we've gone through these many emails is this a research tool, a clinical tool, or both? But I think the big question right now and the big opportunity that we have today is that I need input from you about whether or not this is something that you think would be helpful, encompasses the questions or concerns that you have about your child, and how we can move forward with this. I would very much like to publish this scale so that we can put it out into the community so that it can be refined and validated further. But again, I need some input from you guys. What's going to happen later today, we have some time from 5:30 to 7. If 5 to 7 of you would like to help us out by running through the scale with your children, we can see how it goes. I'm not collecting data on your child. This is not a clinical trial. I'm collecting information on how well this works. At the end of this, I'll give you your numbers. I'm not keeping your numbers, but I'm going to write down how you thought this question didn't go well, did go well, how I should change it better. So that's the input that I need from you guys today. So what I've gone through is I've talked about why I think we need a scale, how we got here. We reviewed very briefly a typical patient. We talked about why I think we can't use the scales that are already out there, and why that we needed to come up with a new scale, and that I need input from you. So special thanks to all of our patients and families with CDKL5. Big thanks to the Rec Clinic, Scott, Margarita, Tristan, Melissa, Katie, everybody in the clinic. Thanks very much to all of our COE collaborators, the NIH Natural History Study, Eric, Alan, Jeff, Walter, and all the other people. Big thanks to Rocky Mountain Red Association, because we wouldn't have a clinic without them. IFCR, who supported us and getting this going from the start. Lulu Foundation, and other support that I have from the Ponzio Family Chair in Neuroscience Research. So, this is your time for questions. So, if I could... Could I ask, we're going to just do a quick straw poll. If you're a family or caregiver, is this something that you like or not? All right, now you got to commit. This is something that I don't like. I have big concerns about it. Come on. Give it to me. Okay. I didn't see any hands unless somebody's just going like this somewhere. Yes, sir. You have a concern. Oh, okay. You have a question. All right. Ask your... So I have a talk this afternoon. The title of the talk is, Dude, Where's My Gene Therapy? So we'll talk about that then. Are there things that are missing in the scale? Is there too much in the scale? I think there's too much. I think that there's questions that I probably need to leave out. All right, you're closest to the microphone, so you go first, and then we'll throw the microphone back.
Not so much a question, Dr. Benke, but I think your point of the fact that whether it should be done in a typical clinical encounter is very important. I think it has to be easily done. Otherwise it's just not going to be done. We have providers outside the Centers of Excellence, and they're busy. Some are in private practice, some are in university centers. But I think to focus on that to make sure it can be completed, with the patients and the caregivers there during that 45-minute, 60-minute encounter, it's going to be critical. I mean, if it ends up being something that's halfway completed, a lot of data is going to be lost. So I think it's a very important point.
No, that's a big deal. We need to try to sell whatever we come up with to those that aren't here in the room, which are going to be the outside clinicians who aren't necessarily part of the Centers of Excellence in the Natural History Study. My experience with enrolling patients in the Natural History Study is it's hard to get a lot of my patients in because they're so sick. But they're going to come see me for a regular clinic visit. But they're too sick to come see me for a Natural History Study visit. And so I'm missing a nice proportion of my patients that we need to capture their data as best we can.
You were asking how often our children had seizures. When our daughter was born, she had seizures every day, multiple times a day. We worked really hard at finding a medicine that would control her seizures. At the end of her life, she would go 6 months to a year or longer without a seizure. If you're asking this information, how is it correct, or it's not a true...
It doesn't really show how severe her seizures were. because she was on so many medicine to help control them. But the severity of her seizure disorder was severe.
So I tried to capture that in both whether or not your child had status epilepticus, so seizures longer than 30 minutes, and I graded how severe the status, and I wasn't able to go through how I graded it, but basically whether or not you had to give a rescue, whether or not you had to go to the emergency room, if you got admitted, if you ended up in the ICU. So even though you might have only had something like that every 6 months, it captured that this was a big deal. And there was a second question that again, a lot of the questions were redundant, but it was those seizures that were severe, but they weren't quite status epilepticus. And what I found is that depending on where you are in the course of the disease, is some families, she's having a seizure for 5 or 10 minutes, but I don't want to give her a rescue because then she's going to sleep for the rest of the day. But that was only happening every 6 months. I still wanted to capture that. So that's still there in a question. And it gets a little tedious, I think, in answering the question. But I think that once your clinician got you used to how these questions were organized, you at home could just go circle, 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 and you'd be done with it in 5 minutes. And so it wouldn't take up that much time during the exam for me to have to ask you the questions again. All I would have to do is say, I see you circled on question 1A a 3, just to validate what you meant and that we were all on the same page with how you scored it. So I'm sensitive to that, and I hope that I can send you the scale and make sure that you feel that it would have captured our daughter. Right. Right. So I'll hand this to you so you can make sure that it's captured in a way that really reflects things. Catherine.
Accurately classify types of seizures. Sorry. When we unroll this scale and get it into the clinics, will there be definitions provided to parents so that when they are at home recording seizures, that we know exactly what they're recording and that they're capturing a tonic-clonic versus a myoclonic versus an atonic, et cetera? So
the question is how can we be sure that we're capturing the different seizure types? And this is of great difficulty to us as clinicians as well, because you can have a child and 5 epileptologists looking at the child, and you'll get 10 different opinions about what that seizure was. And so I've tried to break it up because the difference between a tonic spasm and a myoclonic seizure, go on, tell me, Dr. Epileptologist. It's really hard, but I think that the way I tried to put it in the scale was I wanted to capture the myoclonics in terms of, yes, she's having little myoclonics or he's having a little spasm, but it's not necessarily impacting his day or what he's doing. And so I broke it down into it's disruptive or it's not disruptive so that we can capture the two, but we're not going to split hairs and have to go through me dancing out at every visit. Did he do this and then did this? But we can capture what's the most problematic to you. That's how it, as it iterated, that's kind of where it ended up. Yeah. Sorry. I'm going to get to you, sir. And she's got the microphone, then we'll throw it back to you.
I have the microphone, which means I have the power, ladies. Gentlemen. No, my question is, right now our daughter is having numerous different types of seizures, and we're still trying to switch medications, things like this. Our daughter is 6 years old. She's currently in school. We have an amazing school system with a great support system, and we actually created we have a communication system each day back and forth from school, We have a seizure logger that says, this is what we have noticed. We think this is the type of seizure. This is how she was acting during it, how long it lasted, how long she reacted afterwards, all these things. With these questions on the questionnaire, would you feel it would be a good idea not only for the parents to be involved, but maybe for the educators to be involved too, to get their side of the view on it?
So that's a great point. How do we get... So it would require that you, as the parent caregiver, are getting feedback from the school, because, that's 8, 10 hours a day sometimes, when transportation is involved, that you're not with your child. And so we know that there's also the time during the night when you're not necessarily seeing your child. So it's going to be important that you are getting from all your different sources a gestalt of how many seizures that your child is having. And we know historically through other clinical studies that counting seizures is a very problematic, it's not a science. It's very problematic. You always go either way with over and underestimating your seizures when you compare it to a gold standard with an EEG. And this is a difficult thing because that's what, we were talking before we came in here. What the FDA often wants us to do is to focus on seizures and counting them when we all know that it's not the easiest thing to count. Yes, sir, in the back.
Hold on. Other response to that is I was thinking I would just work with your provider and determine what are our seizures, and whatever you decide what your seizures are and what categories is just being consistent. As long as you're consistent, these are what they are, and this is what we're going to categorize those are, and that's what we're going to circle. Just be consistent. As long as you're consistent with whatever you then chart, you're good, because then you're just, these are what they are, this is what we're going to chart them as, and then you're consistent with your paperwork, and that's all we're trying to do is capture that, because as long as, that's what we're trying to do, is just capture the best we can. And I think we're looking at numbers and things and whatever, and I think as long as we're able to do that, that's what we do. And working with your provider and what you categorize them as is the best you can do. That's the best anyone can do, really.
So my question is, as like all of us know, things change so quick with CDK, like the seizures change. I know we're trying to focus on 30 days, and like right now we've been going through some med changes. Is that taken into account anywhere? Like if you're just started a new med in this 30-day period when you fill this out, and then things may be going well at this point in 30 days, and day 31 everything goes to hell, because that's what happens. I mean,
so again, it's never going to be
right.
Perfect, but the consensus was, as we iterated through this, is to get a general focus on the last 30 days is probably more accurate than saying, well, how have things been over the last 6 months? I can't remember what I did 6 months ago. So I see your point. I mean, the point is okay, you caught me at a good moment or you caught me at a bad moment just when I happen to come see you. And how accurate is this?
I mean, I think it's a great idea.
Right.
Thank you for working on it. I think it's better steps.
Right. So the questions, while there's a focus on the last 30 days, there's also kind of, over the last 6 months does factor into this, because I recognize that you may not be going to see your neurologist, but maybe twice a year. And so has that in mind.
Tim, hi. Thanks. Great talk. It's Lorianne over here.
Oh, there you are. Sorry.
Yeah. So the question I have is, for your severity scale, do you have any anticipation in the relatively near future that this could be incorporated in some manner into, a randomized controlled trial?
I've been emailing you my scale so that you can use it.
Yeah. The real question that I have.
Please use it.
Yeah,
It's useless if you don't use it.
It's not useless if we don't use it, actually.
So-
It provides really good natural history data as well. So, but if we were to use this in our clinical trial, what would you recommend? So, for example, there are some things that we could definitely implement into the clinical trial for sure. The one area that would be difficult would be seizures, ironically, because we capture seizures in a very compulsive way using electronic diaries, and it's not a 30-day viewpoint, it's a day-to-day viewpoint. We have a lot of granularity around what the subtype of seizures are. We have the Epilepsy Consortium, et cetera. And so, and what we can't have are two sources of information that potentially conflict, because that creates an audit problem for us with regulatory authorities. So is it possible that this battery could be, could be like Legos almost, where you can take a couple Legos out?
Absolutely. I mean, that's why I broke
and
it
do
up.
everything but the epilepsy, for example.
That would make complete sense. I mean, you've got questions that, the epilepsies, that's why the epilepsy is its own section, so that it could be, we're going to do just, sections 2 through 5 of the CCSS. So I don't see why you couldn't. It'd be nice. You might be able to abstract from the data that you're collecting into section 1, if we were to do that later, but I don't see why you couldn't.
So it doesn't invalidate, taking apart doesn't invalidate the whole?
I don't think so. I mean, yes, it's really, because it's all of CDKL5 that's in the scale, I don't see how it would necessarily invalidate it. I mean, it's not a validated scale yet anyway, so it's there to be used. Thank you.
I have a question about this specific question about their ability to walk, and I think you need to define that piece a little bit better, because as an example, so my daughter's at 4.5. If you put immobilizers on her knees and AFOs on, and you have someone holding her, she will take steps. So but she certainly can't do any of that on her own. So
I would put that in the category of walks with assistance.
okay.
And so then she's the category of walks with assistance, but then how far she's able to walk is broken down into whether it's greater than or less to 25 feet.
Okay.
So it would capture.
The amount of assistance, I think, just maybe there'd be a definition in there, because to me, it might just, if I'm just holding her hands and she can walk
Well, and
for
again,
a period
it's
of time,
it's,
that's a
it's,
little
it's
different than.
It's pretty broad,
Okay.
because assistance can be just no AFOs and I'm just holding her hand, or it could be AFOs and knee braces and a handhold. It was going to get crazy,
Okay.
so I just said, let's see how it looks there. So basically, if she's walking with assistance, and that's any sort of assistance, but not independent, but greater than 25 feet, she'd be a 3. Less than 25 feet, a 4.
Okay.
So, and again, I know there's a big difference between that and not walking, because but we had to come up with how to score people one way or another.
So I wanted to take an opportunity to get some of the families to give some thoughts about what I'm about to say. So when we're thinking about being able to complete this in a clinic visit and the complexity that we have in this scale, the depth that we have in this scale, I actually wonder, based on some of the comments that we've had, whether or not there's a historical piece and whether or not there's a piece that could be completed by families and whether or not there's a piece that has to be completed by a clinician, and whether those should be separated as a way to simplify what has to be done in a visit versus what has to be done or could be done at another time. But the really important thing about that is that families have to actually be able to do that at another time, and I recognize that's not easy. And so I wanted to get thoughts about that, right? Do we have to simplify the whole thing and capture you when we have you hostage in that visit? Or can we pull out some parts of that and we think that that'll actually be realistic?
So at the moment, it's got these blue sections, and then it's got the green sections, and those are the sections that you get to fill out beforehand, and then it's got the white sections that the clinician fills out based on the exam. So that's kind of how it's broken up, color-coded at the moment.
I'm over here. I'm from CDKL5 Canada, and we don't have a Center of Excellence, but we do have 2 pre-existing Rett syndrome clinics that will take our CDKL5 children. And I was wondering if it would be possible for us to be able to share this scale with the 2 doctors who are running those clinics.
Yeah, I don't think the trade embargo currently covers this. So, yes, I'm happy to do that, and I will face the consequences. Carol Ann, give it to me.
Are you ready for me? So at the beginning you said that you would give the scores so the parents could go away with the scores. What do the scores actually mean?
And I think that's a good question, because let's say I give you a score and your epilepsy score is 9 and your autonomic score is a 4, and the question, until we validate that and we look at patients over time, I mean, if your total score is a 35 this week and 6 months from now it's a 36, is that really meaningful or not? I would say, a 1-point difference is probably not going to be meaningful, but we don't know that yet until we implement it, say in a clinical trial or a natural history study, to really say that you having a score of 35, this is my dream, by the way, you have a score of 35, which correlates with what your visual evoked potential looks like and your auditory evoked potential looks like, and I know that if I put you on this drug, it's going to help you better the next time I see you. That's what I would like to be able to say with a given score, but until we start to use it and correlate it with these different things, I won't be able to say that a 35 is a good score or not. And I do worry that if I give you a score, that you're going to take away from the visit something that isn't as positive as I would like you to feel from the visit. Like, okay, we see there's problems, but we have a plan here that I think is more important than you just focusing on score. That's always a concern that I have, that you're going to focus on your number. Is that getting to what you're...
Yeah, I think so. I think, parents will go to the clinic, and social media as it is, they'll start comparing.
Right.
It could be quite, my daughter could be really good today. In 6 months I come and see you, and
right.
she's had a real dip and a real big jump, and that could be quite depressing. And I just wondered how you would manage the expectations of parents.
Well, I think that it's going to depend on your clinician, and to say your score today is a 35, and you're telling me, I know from what you've told me, and I've scored it here, that today was not a good day for your daughter, and so that's captured in the scale that we have today. I don't know how else to answer that, other than that we as a group need to recognize that it's just a number, and it was just today, and your kid is not a number. And you go back to the first couple of slides. It's about what you can do, not about what you couldn't do today when you were with the clinician.
Yeah, no, I absolutely agree with that. I just think we need to be mindful that we don't sort of get into a scenario where we're staging CDKL5, and that parents think that, along with the Rett stages, that actually they're now in phase 3.
Right. I think because the scale isn't validated, I can't say what the score means.
Yeah.
But I think the other thing is as a group of families, I think that we should consider something about our use of social media, and maybe it's not a good idea to put what your score was today on social media, and that we need to focus on the positive about not what my score was today, but hey, here's this video of what my child did today is maybe a more positive thing to use on social media. The other thing is I think that in clinical trials, we're going to have to agree and we're going to have to abide on that if you're in a clinical trial, that there's going to be a complete social media blackout. Can I get your agreement on all of that, please? Yes? Yes? Okay. All right.
Thank you. Thank you, everyone, for your great questions, too.
That's a fantastic lead-in into our next session, which we're going to go right into. So we're going to go right through the next hour, and if you need to take a quick break, or feel free to do that in the meantime. But we're going to go right into it, if you don't mind. So we're going to go right into our